It's a pleasure to be here. Thank you all for attending. I'm going to spend some time tonight talking about both diving and altitude. That's sort of collectively known as environmental physiology. And to me, the way that the human body adapts or gets by in those environments is absolutely fascinating. And a lot of what we learn in environmental physiology pertains to what we do in clinical medicine. The title is there, which is what you have in front of you, but in fact, it probably should have been retitled as how we sneak by a lot of times. So now, on the left is a very nice picture, which was not taken by me, it's by a friend of mine. On the right, I'm going to minimize the number of graphs tonight, but this is one that I really have to show you. And this is a plot. On the y-axis is pressure. On the x-axis is depth in meters. So the diving environment is very nice for those of us who like very simple math, linear math. And it's even simpler when you realize that every 10 meters equals 1 atmosphere pressure. So it's absolutely fantastic. So this line right here is the plot of atmospheric pressure versus depth. And we also deal with what we refer to as partial pressures, which is the, if you like, the activity or the pressure of a given gas. So oxygen and nitrogen make up air. Oxygen is 20%, nitrogen is 80%, and you can see, therefore, that 80% of the pressure is nitrogen and 20% is oxygen. And these increased partial pressures have certain effects on the human body. For example, nitrogen starts acting like an anesthetic. The deeper you go, as the partial pressure of nitrogen goes up, the brain reacts as if it's being slowly made drunk and eventually put to sleep. That's nitrogen narcosis. And this is important because as divers go down in the water column, they become less and less able, when they're breathing air, to do whatever it is they are tasked to do. Oxygen partial pressure also has its effects, and oxygen at high pressure is toxic. At, should we say, moderate pressures, it's toxic to the lung, and at higher pressures, it's toxic to the brain, causing convulsions and other symptoms as well, which usually results in drowning if the diver experiences that. And then finally, there's an effect that has nothing to do with gas, but it's called high-pressure nervous syndrome, and it's actually only seen when the breathing gas is not nitrogen but helium. And this occurs at depths of about 150 to 180 meters. It's well beyond recreational diving. But it consists of tremor, nausea, vomiting, and difficulty maintaining balance. And it's usually a problem only for very deep divers who are going down in the range of 500 to 1,000 feet or deeper. Now, one of the effects of pressure is that it reduces gas volume. And on the left is a regulation coffee cup that probably many of you have drunk from today. And on the right are 4 examples of the same coffee cup exposed to pressure in our hyperbaric chamber. And this is all very interesting, but in fact, it does have biological application because there are gas-containing spaces. For example, the mask of a diver, if the diver does not have the wherewithal to open his or her nasopharynx to the lung, to the trachea, then what happens is, on the lower left, you can see here's a diver at 2 atmospheres or 33 feet of seawater, 10 meters. If the gas pressure within the mask remains at 1 atmosphere because the diver has unintentionally kept their nasopharynx closed, then there's a pressure differential which tends to extrude the eyes and the tissue around the eyes into the mask. And here you have a perfect example of what's called subconjunctival hemorrhage, and you can see some bruising around the eyes as well. Now, this pressure effect can be fatal. This is not something that a recreational diver would experience, but this is a Navy diver who was swimming alongside a submarine. tethered to it, and as the submarine inched forward in the water, it hit a fresh water pocket, immediately sank a couple of 100 feet, dragging the diver with it, and the pressures within the diver's breathing system did not have sufficient time to equilibrate, and he was extruded into his mask and died. Now, some years ago, a diver, or a saturation diver in a hyperbaric chamber at 191 feet had the following pressure experience. He was sitting on the toilet, and coincidentally, somebody outside the chamber opened the valve to empty the tank, and his bowel was extruded into the toilet bowl, which resulted in loss of bowel. A surgeon had to be locked into the chamber where he resected the bowel, and this poor man ended up having to live on IV nutrition for the rest of his life. Now, divers are in order to breathe underwater. When I was a kid, and some of you may have tried this, we had the notion that we were going to walk down to the lake with a garden hose and walk along the bottom of the lake, and somebody holding the hose up to the surface, and we could never understand exactly why it didn't work. Fortunately, it didn't, because we probably would have killed ourselves had it done so. But in order to breathe underwater, you have to have gas delivered to you, not at surface pressure, which is impossible because your inspiratory muscles are not capable of maintaining the necessary pressure. You have to have gas delivered to you at the ambient pressure of the dive. This is no surprise to any of you who are divers. And so you have gas in high-pressure tanks. There's a high-pressure regulator that reduces the pressure down to some tolerable level, then a low-pressure regulator, which allows the diver to inhale the breathing gas. And one of the problems associated with that is that as the pressure increases, the gas density goes up as well. So here we're at 1 atmosphere pressure, and the gas in this room has a density of about 1 gram per liter. If you were to weigh a liter of gas, this is what it would weigh. And if you dive to, let's say, 2 atmospheres, breathing air, then the gas density increases. And what that does, of course, gas going through tubes such as your lungs or your breathing system, the resistance to breathing increases with the gas density. And other problems can occur as well, which we'll get into in a little while. Back in the 1980s, I was involved in an experiment where divers were actually breathing a gas at 17 grams per liter. That was at Duke, but actually University of Pennsylvania trumped us. They actually went to 25 grams per liter, and that had some interesting effects. But Duke actually won the battle because back before I was there, someone actually induced an individual to breathe water. It's a long story. I won't belabor you with the details, but the density of water, of course, is 1,000 grams per liter, and there were 2 accounts of it. One was the man said that he felt like he was drowning. The other was he said it felt perfectly fine. I think it depended on who he was talking to. But it is possible, actually, for humans to breathe water just like fish. Now, how do you measure the effects of gases on the breathing system? And one way is by having someone take a big breath in and then blow into a device such as this one. This is basically a person blowing into a drum. As the person exhales into this, the drum moves upwards, and this is an old-fashioned version, but it illustrates the principle very well. A pen moves on the rotating drum here, which has got an ink stylus on it. And what you get is a plot of exhale volume. So this is the start of the exhalation. This is the bottom of the exhalation, the end of the exhalation, and you get a curve which gives a plot of exhale volume versus time. This is a flow, volume time graph, And you can measure the total amount of gas exhaled, for example. You can measure the total amount of gas exhaled in 1 second, which is called FEV1. You can use this technique to see how much the increase in density affects breathing. This is an experiment we did some years ago. This is Heather Mummery, who's now Heather Frederick. She was a medical student, and she was interested in looking at aging divers. So we had a group of individuals, 65 years of age and older, and we had a younger group. And she was looking at the differences. And just to show you an example of the kind of data that you can get, the graph on the upper right is FEV1. That's the amount of gas you can exhale in 1 second in young people and old people. And the blue bars represent the surface, the yellow bars represent 60 feet of seawater, and you can see that at 60 feet there's about a 10% reduction in the amount of exhalation you can get in 1 second. This is due to the increase in gas density, and of course the deeper you go, the greater this effect. Now, another issue was brought up by an investigator named Hans Kielstra back in the 1960s, and if you think about it, the end of the gas goes through your mouth into a branching system in the lung, and the end pocket, if you like, is the alveolus. It's a little tiny 200 micron diameter pocket where gas exchange occurs, and I'll show you that in a minute. But we don't know exactly why our alveoli are the size that they are, but it has been suggested that they're absolutely ideal for diffusion of gas. And diffusion means that, of course, oxygen has to get from the interior of this to the outside, and carbon dioxide has to get from the blood to the rim of the alveolus to the inside, and then eventually be transported out. So you have these diffusion gradients within the alveolus, and the theory goes that the more molecules you pack in there, i.e. diving, means that you will interfere with diffusion. And there's a lot of concern about this back in the 1960s and 70s, that divers would not have sufficient oxygen in their blood because of this diffusion problem. Well, this was confirmed by an investigator in France named Dr. Chouteau. And Dr. Chouteau had goats in a hyperbaric chamber at a depth of 1,280 feet. And the fraction of oxygen was sufficient to produce the same partial pressure of oxygen at 1,280 feet as the partial pressure of oxygen in this room, which is, the number doesn't matter, but it's 154 millimeters of mercury. What he then did was he added helium to the chamber and increased the depth from 1,280 to 1,820 feet of seawater, and he hypothesized that if diffusion was going to be a problem, that the goats would start to act like they didn't have enough oxygen. And sure enough, that's exactly what they did. Now, he didn't take a photograph, he didn't take any movies, but he drew a picture of what the goats looked like, and you can see these goats are really acting weird. He then added some oxygen to the chamber, and all the goats got up and looked absolutely fine. And this was called the Chouteau effect. And this governed the amount of oxygen for the next 20 years inside deep hyperbaric chambers until Dr. Salzano, who was a mentor of mine at Duke, decided, well, what we need to do is actually measure the amount of oxygen in the blood. And a series of deep dives was done back in the late 80s, late 70s, early 80s, called the Atlantis series, and ended up at a depth of 2,250 feet. Here are three of the divers. You can see it's pretty cramped quarters. This fisheye lens sort of makes it look bigger than it really was. And what they did was they put arterial catheters in each other. You can see this is, if you know anything about drawing blood and all that kind of stuff, you know that nowadays everybody wears gloves and what have you. This is clearly 1980s because nobody's wearing gloves, and there's also a mess on the table. So they were able to put arterial catheters in each other, and what they found was that the level of carbon dioxide in the blood increased markedly, and I'm not going to belabor the graph, But the oxygen remained absolutely fine. So this is PO2, and this is gas density. So these points here represent the experiment during room air at the surface, and you can see that all of these points, this is between 200 and 400, they were breathing high oxygens, of course, they were all absolutely fine. So it's not clear exactly what Dr. Chouteau's goats were doing, but it wasn't because of low oxygen. Now, diving comes in a couple of flavors. One is what's called a bounce dive, and it's called a bounce dive because you go down, you spend a relatively short period of time on the bottom, and then bounce back up. There may be some decompression stops along the way, which we'll talk about in a minute. Or, if you're doing a job on a pipeline at the bottom of the ocean, and it requires a lot of work, a lot of time, a lot of welding, or whatever it might be, what will probably occur is what's called a saturation dive. And what that means is that divers are locked in to a hyperbaric chamber on the deck of a dive support vessel, and then for a shift, they enter a diving bell. The diving bell is connected to the hyperbaric chamber. It's then disconnected, lowered down to the work depth, and then usually contains two divers, one of which goes out and does his thing, gets back in the bell. The other guy goes out, does his thing, back in the bell, seal it up, back up on deck, mate back to the hyperbaric chamber, and then Miller time. And then another two divers goes down. So you can run a 24/7 operation, and the pressure within this hyperbaric chamber doesn't change. The pressure here is very close to the pressure on the bottom, and so nobody is decompressing or compressing. And then at the end of whatever it might be, a few days or 2 weeks or longer, the entire system is slowly decompressed, and it often takes days to get back to the surface. So this is saturation diving. Now, there are other problems associated with that, of course, one of which is temperature. When you go down to beyond recreational depths, water is very cold, and especially at those deep depths, it's usually around 40 degrees centigrade. And so there have to be ways of keeping the diver warm. One way is by using hot water, and that's exactly what happens with saturation diving. Hot water is generated on board the dive support vessel. It's pumped down to the diver, and then it comes out on the inside of his suit and keeps him warm. There are other, should we say, more sophisticated devices that are being developed by the Navy, which of course you can't, if you're sneaking into someone's harbor, you can't obviously be connected to the surface in any way, so you have batteries and what have you. Now, decompression is one of the real challenges of diving, and on the left you can see a rat that has experienced a decompression event, and his eye is full of bubbles. And what's going on here is exactly what happens when you open a carbonated beverage, and all of a sudden the carbon dioxide forms bubbles. And in this case, in the diver's case, it's not carbon dioxide. What it is, it's nitrogen or helium or whatever inert gas is being breathed. So these bubbles occur. I've never seen this in humans. I don't know that it ever exists. But it does occur in the spinal cord. It occurs in joints and other places. I'll show you a couple of examples in a minute. And this is called decompression sickness. Decompression sickness. Now, another way that gas can get into the system is if a diver does not have the wherewithal to exhale during decompression, if he holds his breath, what happens is, as the pressure is reduced, his lung will expand and expand and expand, and eventually these little air sacs in the lung will rupture, forcing air into the blood vessels where it can go all kinds of places, including to the brain. And this is called arterial gas embolism. These two, decompression sickness and arterial gas embolism, if you want to talk about either one or both, it's called decompression illness. Now, here's an example from the early part of the 20th century of decompression sickness. This is somebody who experienced spinal cord decompression sickness and is paraplegic, can't move his legs, and you can see he's kind of wasted. He died a few days after this photograph was taken, probably from a bladder kidney infection, because what happens in this disease is loss of control of bladder and bowel, And of course, once that happens, you have to catheterize the patient. In those days, they had very little sterile technique and certainly no antibiotics. I'm not quite sure what this device is, but it was probably some sort of electrical system that was designed to improve his strength, and of course it didn't work. These are two examples of skin bends. This is called Cutis marmorata. This is usually a fairly benign type of decompression illness. People who get this pattern of skin bends tend to get it repetitively. There's something about their makeup that predisposes them to this particular type of bends. And here's an example of what's called lymphatic bends. You can notice this is a male. His breast size is increased here, and this is 2 months later when everything was back to normal. He called me actually one night from Indiana in January, and I don't know who dives in Indiana in January, but he had this, and I got him to send me the digital picture. We got him vectored to a hyperbaric chamber, and he got better. Now, of course, most people dive not in hyperbaric chambers, as I showed you earlier, but in water. And immersion itself actually has some very interesting physiology associated with it. We're all sitting or standing in this room, and there's a tendency for blood to pool in our legs. Gravity tends to pull blood downwards. And in fact, pooling of blood in the extremities can be a problem. As you know, when soldiers, particularly inexperienced ones, have to stand at attention on a parade ground for a long period of time, sometimes they faint. And what's happening there is that they get tired after a while, they lock their knees. The muscle tone, which helps maintain blood, keeps blood out of the veins by contraction, they lose their muscle tone, more blood pools in their extremities, and essentially they faint because they've hemorrhaged, they've bled. Now, of course, as soon as they lie down, everything is back to normal. Now, in water, the opposite happens because the density of water and the density of blood is almost the same, and so blood that is pooling in the lower extremities gets moved elsewhere, usually up into the thorax, into the heart. The heart gets a little bit bigger, the blood in the lungs increases, and so you end up with this increased pooling of blood in the thorax, which most people don't notice unless they have a heart condition. But in certain circumstances, it can be a problem. Now, here's an example of that. This is a 37-year-old physically fit female physician, and she was training for a triathlon. After swimming in the water during this, she felt a little fatigued. She had a bit of a wet cough. And then a few days later, she did it again. Water temperature was quite cold. She lives in Colorado. And after 200 meters, she was severely short of breath. She called for help. And then when she got to shore, she was coughing up blood. And when the EMS arrived, her heart rate was 200 beats per minute. And when they put her finger in the pulse oximeter, the normal reading is 98, 99, 100. Hers was 55%. And she had a chest x-ray that showed fluid in her lungs. This is pulmonary edema, so-called. And they investigated her for heart problems, but everything was completely normal. So this is what's called immersion pulmonary edema. Now, what's going on here? So this cartoon in the upper left shows the small blood vessel, capillary, that goes past the alveolus, and the purpose of this whole construction here is for carbon dioxide to get out of the blood into the alveolus, and oxygen to go from the alveolus into the blood. Now, what that means is, functionally, this membrane, this space between the blood and the lung and the alveolus has to be very, very thin, because gas has to diffuse in and out. Now, an actual photograph of what it really looks like is in the lower left. So these areas here, this is the alveolus, this is this thing right here, and at the corners of these alveoli are blood vessels, and this is a completely normal lung. The lower right shows what happens in pulmonary edema. This is, these alveoli are now full of fluid. It's like drowning, essentially, because For some reason, blood or fluid has moved from the blood vessel, from the capillary, into the alveolus. And one possible reason for this is the pressure in here is too high. The pressure is excessive, is abnormally high, and that exudes fluid from the blood into the alveolus. Now, we were interested in knowing whether during immersion pulmonary edema this was in fact the case, because another possible reason is that there's something going wrong with the membrane. Inflammation and some other things can actually make the membrane leaky, and we thought that's another possibility as well. Well, we can't measure the pressure in the capillary because it's too small, but what we can do, we can measure the pressure in the blood vessel, in the main pulmonary artery. We can put a catheter through a vein, thread it through the heart into the pulmonary artery, and we can, this is called a pulmonary artery catheter or a Swan-Ganz catheter, and there's a little balloon on the end which you can inflate. And what that does is it blocks off one of these blood vessels, stops the flow momentarily, and if there's no flow through here, then the pressure at the catheter tip is equal to the pressure downstream. So although we don't know the pressure in the capillary itself, we can measure the pressure upstream and downstream, and what's going on in the capillary must be somewhere in between. So this is what we did. On the upper left is Ann Cherry, who was a medical student at the time, who was working on this project with me. She's now a faculty member at Duke. You have to put these catheters in under X-ray guidance to make sure they're in exactly the right place. And in the upper right is the setup that we use. This is a pool of water. We put the catheter in. We made people exercise underwater. Before we did that, we exercised them in the dry, and what you see here is one of our volunteers. Here's the catheter actually going in through one of his arm veins. It's ending up in his pulmonary artery, and the lower right shows the same setup. Now, here are the numbers that we get. I think this is only the second graph I'm going to show you. So what we did was we studied people at rest, and we measured the pressure in the pulmonary artery, and we measured what's called the wedge pressure. That's what happens when you blow the balloon up, and the pressure is now equal to the pressure downstream beyond the capillary. So this is the pulmonary artery pressure and the wedge pressure. And we then exercised these individuals, and we got the relationship here that everybody else has gotten. So when you exercise, your cardiac output, which is the amount of blood going through your heart, goes up, and the pressure in both the pulmonary artery and the pulmonary capillary go up as well. We then studied under the same circumstances. This is during cold water. We studied in the same circumstances a group of people, 10 people, who had experienced immersion pulmonary edema. And this is what we got. So look at the yellow symbols now. This is pulmonary artery pressure, and this is pulmonary artery wedge pressure. And you can see that at a lower cardiac output, these people had a significantly higher pulmonary artery and pulmonary artery wedge pressure than the random normal people. So there's something different about people who get immersion pulmonary edema. Now, the next thing we did was we got them out of the water after this. We gave them a Viagra pill, and we repeated the study sort of after lunch. Why do we use Viagra? Because Viagra lowers pulmonary artery pressure. It's often used in people with high pulmonary artery pressure for other reasons. And we found that the pressure in the pulmonary artery and the pulmonary artery wedge pressure both came down. So what does this mean? Well, it means we've identified a problem with immersion pulmonary edema susceptible people, and we found a possible drug that might help them. And in fact, one of our study subjects was so enamored with this that she asked me to write a letter to her cardiologist, which I did, and she now takes Viagra before every one of her triathlons, and she hasn't had a problem since. Now, once in a while, triathlons are becoming very popular. There are now hundreds of thousands of people in the United States who participate in triathlons. But once in a while, there's a death. And it's often a young, healthy person. This young lady died, this is 2011, in the New York Triathlon. She's only 40 years old. She didn't have any cardiac risk factors. And one possibility, I think, is that some of these people are dying of immersion pulmonary edema. In fact, Scientific American shortly afterwards wrote this, published this article, "Why is swimming the most deadly leg of a triathlon?" And all kinds of reasons were suggested, but I think it might be indeed immersion pulmonary edema. Now, I'm going to show you a little video. I hope it works. I think it will. Just to give you an idea of what nitrogen narcosis looks like. This is a film made by the BBC. These individuals are in a hyperbaric chamber at 80 meters. So it's quite deep, maybe 250 feet or so. And you'll see that, number one, they start acting a little silly because nitrogen narcosis is a very reversible drunk. And they have various tasks to do, which I'll show you in a moment. So the guy in the red shirt, his job is going to be to do some arithmetic calculations, and the guy with the glasses is going to take a pair of tweezers and put ball bearings in this vertical tube. So the experimenter says to go, and the red shirt guy is starting to do his calculations. The other guy is doing his mechanical task. And one thing you'll notice in a minute is the guy who's supposed to put ball bearings in the tube gets distracted and starts watching the other guy, which is absolutely typical for nitrogen narcosis. People become very distractible. And you can imagine if you're trying to do something very task-oriented, you're trying to rescue someone, or you're trying to do, here you go, you see. Then nitrogen narcosis can be a real problem. And in fact, commercial diving does not occur at depths deeper than 165 feet breathing air. Deeper than that, they breathe helium, heliox. Now, the next little video shows oxygen toxicity. So this is, this first part is from World War II, when rebreathers were first developed. And the reason is that if you're trying to sneak into a harbor and put an explosive charge on someone's ship, you don't want the bad guys to know what you're doing, and therefore you don't want bubbles. And so these divers breathed 100% oxygen. They rebreathed the oxygen. It went through a CO2 scrubber, and then they could get in and out of danger, at least without giving away their position as they would if they were using scuba. Now, the next part will show you what happens when you breathe oxygen at a high pressure. So this is just more of the same. This is, again, World War II. What you see here is a hyperbaric chamber, two men in a hyperbaric chamber at about 100 feet of seawater. And the guy lying down is breathing 100% oxygen. You notice his eyelids are starting to twitch. He's hyperventilating. And in a moment, he's going to have a full-fledged grand mal seizure, just as if he were having an epileptic convulsion. And this, of course, this is an oxygen seizure. You can only imagine what would happen if this occurred underwater. And in fact, those World War II guys discovered that. Some of them were lost because they had seizures underwater. And of course, if this happens, drowning almost invariably occurs. All right, so much for pressure. Now, what I'm going to do here on this graph, so this first part is 1 atmosphere, and I'm going to expand it up to here. So now this is 1 atmosphere, and we're going to go to altitude, and this is now the air pressure. And unfortunately, at altitude, unlike diving, where everything is a nice straight line, the relationship between pressure at altitude and altitude itself is a curvy line. So you can't do the calculations in your head. You have to look it up in a table or go to your calculator. And almost all of the problems in altitude are due to low oxygen partial pressure. What you see here is you can see increasing risk of, and this is acute mountain sickness, high altitude pulmonary edema, and cerebral edema. We'll talk about that in a minute. if you happen to be going to altitude in a military aircraft, then you can actually get decompression sickness flying. This is not something that you can get if you climb a mountain. If you can climb a mountain fast enough to get decompression sickness, you will end up in the Guinness Book of World Records. Now, altitude investigations really got off the ground, no pun intended, back in the 19th century when there was sort of a space race between Britain and France, who could go the highest and all that. And this experiment in 1875 occurred with three French adventurers. They took off from Paris, and they reached, this is a plot of their, this is time versus altitude. They actually reached an altitude close to the summit of Mount Everest. And they started sinking down, and then they threw everything they could out of the gondola to try and get higher because they wanted to set a record. They already had done so, but this dotted line means they didn't really know what altitude they reached. At this point on the descent, one of the men regained consciousness. The other two were dead, and this was a disaster. This was like the space shuttle, and they realized that they were playing with fire. Now, there have been similar attempts to set world records. In 1960, Joe Kittinger jumped out of a balloon at 100,000 feet and parachuted safely to Earth. Now, he could not withstand 100,000 feet without being in a spacesuit. You would die instantly if you jumped out at 100,000 feet. In 1966, Nick Piantanida tried to best that record. Unfortunately, there was a problem with his suit. He was decompressed and he died. And then, courtesy of Red Bull, Felix Baumgartner in 2012 beat the world record. He now holds it. You can go online and you can see dozens of nice photographs and videos of all of this. Red Bull provided a very nice videographic service. Now, altitudes are shown here, a few altitudes of interest. So here we are in Pensacola at 0 feet, or maybe we're 10 feet above sea level here. The highest place in continental United States is Leadville, Colorado, at about 2/3 of an atmosphere. If you can go actually higher than that to Alta Ski Resort. The highest place in the United States that you can sort of almost conveniently go to is Pikes Peak in Colorado. You can actually drive up to Pikes Peak. I wouldn't recommend it because there are crazy drivers there, and the altitude really gets to them. The highest place that men have actually lived is in this unused, disused mine in Chile, about a half an atmosphere, and of course Big Daddy is about 1/3 of an atmosphere. Now, altitude has some interesting effects. This investigator in 2007 published a nice review of 1,460 soccer matches in South America, which were held at various altitudes. And what he showed was that the home team, the team that lives at higher altitude, has an advantage over a team at lower altitude, not surprisingly. So if you're betting on the Super Bowl using this statistic, you'd bet that Denver is going to beat the other teams because they live at higher altitude. Now, it turns out that you can go to high altitude for quite a long time, and you can walk and you can hike and do fine. You can climb, but if you're going somewhere, you have to do very accurate, detailed cognitive work, such as this is the cosmic background imager in Chile at 5,000 meters. If you're doing spreadsheets and stuff like that, you really can't concentrate quite as well. So this is a place where they actually enrich the oxygen. They bring the oxygen up to 27%, and the guys who do their computer stuff say that they feel a lot better. Who cares about altitude? Well, there are some hospitals at high altitude. This is one at Leadville, Colorado at about 10,000 feet. And if you care to go to Kunde in Nepal, there's a hospital at 12,600 feet. Interestingly enough, this is a photograph of David Murdoch, who was a physician later at Duke. And here he's amputating someone's finger under general anesthesia. You notice there's nothing connected to the patient. He's not getting any oxygen. But he's acclimatized to that altitude and did just fine. The other group that care are the states of Utah and Colorado, because a lot of people go to ski there, they get sick, they don't feel well, they go home, and the money that they would have spent goes home with them to the detriment of the Colorado and Utah economies. So these two states put some money into altitude research. Now, I'm not going to belabor this, but just to show you some numbers here. So here we are, the PO2, the partial pressure of oxygen in the room here is about 159. It goes to the alveolus and ends up at a partial pressure of about 100 in the blood. If you go to 15,000 feet, the partial pressure of oxygen is now 89, and the partial pressure of oxygen in the blood is about 36. Now, one of the adaptive mechanisms is that people, if you want to increase your oxygen, you can lower your carbon dioxide, and people hyperventilate, that is, when they go to altitude, to a varying degree. And here's 3 experiments where people have actually measured what's in the blood at various altitudes. This is a study done at Duke University in 1983. Where we studied people during exercise. This was a simulated climb of Mount Everest conducted by the Army in 1985. And this is a British expedition where they actually wanted to measure blood gases in real people on top of Mount Everest. Unfortunately, it was too cold that day because you have to kind of strip down to find an artery. And they went down to a slightly lower altitude where they felt they weren't going to get frostbite. They then gave the samples to a Sherpa who ran them in a thermos down to the lab where they measured the numbers. And just to show you the numbers, so this is oxygen saturation here at sea level. As you know, 99% is the normal. On as close as possible to Mount Everest, this is in an Army lab, oxygen saturation of 58%. Now, the degree to which you can climb mountains depends on what's called, in part, on the hypoxic ventilatory response. So if you lower PO2, if you go to altitude, the normal response is to increase ventilation. So people hyperventilate, and what that does is it drives their carbon dioxide down, and therefore their oxygen up. And if you have a curve that looks like this, you can arguably go at Mount Everest, but some people have a curve that looks like this. They do absolutely fine in everyday life. They live at sea level or whatever. But these people can't do much more than walk from the beach to downtown Pensacola. They definitely should never go on a mountain. Now, of course, the mountaineers say, well, you know, you academics, ivory tower types, or you can do all the stuff you want in the lab, but real men and women climb real mountains. And there's much more to it than just the oxygen. It's cold, it's blowy, and this is a photograph of Conrad Anker and his team. They went to find out whether they could find the bodies of Mallory and his buddy Irvine, because the mystery to this day is, did these guys actually climb Mount Everest? Were they killed on the way up or the way down? Now, nobody climbs Mount Everest without taking a picture from the top. So they knew that if they had actually made it, the camera would tell the tale. Unfortunately, they found one body. It turned out to be Mallory, no camera, and today we still don't know the answer to that mystery. Now, just a couple of last slides. I had the privilege of going to Mount Everest Base Camp in 2013, and one of the pieces of data that we had was to continuously record on 9 people pulse oximeters. And what you see here in the bottom, this is one particular day. I don't remember which day it was, but just to show you, one guy is in blue, one guy is in red, and this is the pulse oximeter reading. Now, this is the normal up here, and what you see here is that during sleep, both of these individuals, this guy was around 65 or 70, when he went to sleep at night, back down again. But the guy with the red dots, he was living around 40% at night and only around 60 to 65% during the day. Now, if you ask an average doctor, you know, how low can you go? Would it be possible to live if you had an oxygen saturation of 40%? They would say, well, instant brain damage. We showed clearly that that's not the case. I don't think I have brain damage, although others would perhaps talk differently. Now, climbing mountains is very dangerous, of course, and this just shows you the death rate. This is without oxygen. There's about an 8% death rate on Mount Everest. Even with oxygen, it's about a 3 or 4%. If you try and climb K2 without oxygen, there's about a 20% death rate. So if you choose to do that, make sure your life insurance policy is paid up. I'm going to skip forward quickly because we're running out of time, but just to show you, you can climb mountains just fine, but if you decrease the oxygen sufficiently, then you cannot maintain consciousness. Now, what they've done here, this is two people in a hypobaric chamber, altitude simulation, and what they're demonstrating, this movie was made by United Airlines probably back in the 50s. The experimenter here is breathing oxygen, of course. The flight attendant is breathing air, and she's being asked to put nuts and bolts together. And what you see is she's doing absolutely fine, no problem, at least for now. But she's going to have increasing difficulty putting the nuts and bolts together. And over the few seconds, 30 to 40 seconds that she's doing this, she gradually loses her ability, but notice she doesn't look up and say, oh, I can't do it. She, as far as she's concerned, is doing absolutely fine. And eventually, the guy with the oxygen, as you can see now, she's having problems. He's going to slap the oxygen on her, and had she not gotten supplemental oxygen, she would have lost consciousness. And that's why, for example, you get on a plane, here she is, she's getting the oxygen, and she just keeps on keeping on. People often don't notice that they're hypoxic, but they clearly have problems. You know, it's when you're on the plane, they always say if you're traveling with a small child and the oxygen masks come down, put your own mask on first. That's not what you would sort of want to do. But if you struggle with a child who has no interest whatsoever in the oxygen, you're going to lose consciousness, and the child, of course, will as well. Now, I'm going to move forward on this one. Now, this can have deadly consequences. Payne Stewart, as you may remember, won the U.S. Open, and then when flying from A to B in his Learjet, the Learjet overshot the airport, eventually ran out of gas and crashed because pressure had been lost on board the aircraft. No one realized it. The pilot lost consciousness, as I'm sure he did as well. And everybody on board died. Now, it is possible to go to high altitude and not lose consciousness. So here's Peter Habler, who was one of the first two guys to climb Mount Everest, 30,000 feet, 29,000 feet, without oxygen. And this is a plot of three people. This is thousands of feet. So here's 30, 32, 34, 36,000 feet. And this is what's called time of useful consciousness. So at 30,000 feet, for example, these two guys had useful consciousness of 100 and 150 seconds, respectively, whereas this guy, who lived at high altitude, probably could have lasted forever without losing consciousness at all. So there's adaptive mechanisms which we really don't understand very well. But partly, it's shown here. This is my son, Peter, who had his wrist oximeter on during the Everest trek. He came with us at Namche Bazaar at 11,200 feet. His was reading 79% on the way up. 13 days later, on the way down, exactly the same altitude, his pulse ox was reading 88%. So this is part of the adaptive mechanism. This is acute mountain sickness. This is you can see he looks like he feels terrible or feels like he looks terrible. Nausea, headache, vomiting, and these other things, edema and difficulty sleeping. Finally, this is all very interesting because we all started life in the womb very hypoxic. We were born into this oxygen-rich environment. We lost our adaptation to oxygen. We know that it's possible over time. If you climb mountains slowly, you can readapt to hypoxia to some extent. But what if we had a pill? What if we had a drug that would instantly readapt people to hypoxia? That would be a huge medical advance. because it would enable us to take care of patients with heart and lung disease in ICUs without using additional oxygen, which of course is toxic. So just to show you that, here you have the arterial PO2. These are normal values. Arterial PO2 90, PCO2 40, pH 7.40. These are absolutely normal values that everybody in this room would have. But in the fetus, in the mother's womb, arterial PO2 15, and in the umbilical vein, which carries blood from the placenta to the baby, 28. Now, everybody would be unconscious and arguably dead with those numbers as an adult. So what happens when the baby is born, and how do you adapt to hypoxia? We really have very poor understanding. So I'm going to stop there and take any questions that you might have. Thank you very much for your attention. This gentleman here.
This is sort of a continuation of what you're talking about. How can hyperbaric oxygen or hyperbaric chambers be used to treat infections? Specifically, what type of infections, and where in the United States are individuals competent in doing that?
Yeah, very good question. So hyperbaric oxygen is breathing oxygen at high pressure, and the types of infections that are amenable to that include gas gangrene and other necrotizing infections. These are very rapidly spreading infections, so-called flesh-eating disease. Sometimes you see that term used. These infections usually occur, but not always, in people who have underlying immunologic compromise of various types, or they're taking drugs to suppress their immune system because they have transplants. But they're absolutely 100% fatal, and they require antibiotics, surgery, and hyperbaric oxygen as well. In terms of where hyperbaric oxygen chambers are, they're scattered around the country. I don't remember exactly how many there are, but every state has them, and they're pretty easy to find.
Thank you.
Thank you. Question over there.
Thank you. My name is Dan Anderson. I teach disabled veterans to scuba dive as part of their therapy. I was wondering, for HBOT, what's your minimal partial pressure of oxygen used to show any kind of improvement on traumatic brain injury, which is most of what we have?
Yeah, that's a very good question. Traumatic brain injury is something that has been heavily studied, funded by the Department of Defense, because obviously there are a lot of veterans returning from deployment with that problem. To date, unfortunately, the studies that have been done have not shown any benefit of hyperbaric oxygen. So I hate to be negative about it, but that's the evidence that we have so far. Sir, yes.
Thank you so much for all this incredible information. You quickly talked about breathing water. And I have a friend who is an extremely smart guy, a swimmer, and he talked to me about that once. And would you elaborate, please?
Yeah. So fish breathe water, and of course they extract oxygen from the water and they excrete carbon dioxide into the water, and they're built for that. One of our investigators from years ago was interested in knowing whether it would be possible to breathe liquid, and the way that was done was a tube was put into his trachea, which allowed separation of the lungs, because nobody wanted to fill both lungs with water. And once that was done, a salt water solution was instilled into one lung, and he breathed that hyperoxygenated water, essentially. And Dr. Kilster, who was running the experiment, demonstrated that he was able to maintain, at least for a very brief period of time, his oxygenation and carbon dioxide exchange. So that's, is a little bit of a scientific curiosity, but the long-term benefit, if it were possible to do that for divers, then decompression sickness would no longer occur, because you wouldn't need to add all this extra nitrogen. So theoretically, anyway, a diver could go down, do his thing, spend as long as he wanted, and then come back to the surface.
Thank you.
Sir.
Thank you. Some authors have mentioned that the industrialization of the planet has reduced the concentration or maybe the ratios of vital gases that we desperately need. Anything to that, or is that just theory?
Yeah, good question. So carbon dioxide has increased in the atmosphere, of course, but it's still at very low levels in terms, and it has no physiological effect at those levels. It may affect climate, yes, but not human physiology. The oxygen levels have actually been pretty stable for probably millions of years. At one time, oxygen levels were much higher. We're talking about probably tens of millions of years ago, and at that time, insects and creepy crawly creatures, because of this additional oxygen, since they depend on diffusion, they were able to grow to huge dimensions. So centipedes, fossils of centipedes, this big have been found. I can't imagine hanging around at that time, but that was the upshot. Question at the back.
This isn't scientific at all, but the Patriots are playing Denver at home, 3-point favorite to the Patriots. I don't think the ball's going to be inflated. Would you say take the points in Denver?
Well, the statistics would favor Denver. If they played hundreds or thousands of games over time, I think they would win most of them. Thank you very much.